afternoon to everyone. Thank you for joining today to this webinar that we will focus on foveal hypoplasia. We bring humbling our experience on that, and I try to organize this webinar together with my genetics unit. So we'll meet Dr. Fortunato, that is my colleague, and she's a pediatric ophthalmologist who's focused on inherited retinal diseases like me, and expert also in retinopathy maturity management. And Dr. Sara Bargiacchi, she's a clinical geneticist here in Florence, in Mayo Children's Hospital, and she's the leader of the eye genetics unit from the molecular point of view. So I strongly wanted to involve them in this webinar because we'll try to give you a glimpse on not only on the theoretical part of the foveal hypoplasia, but also on what we do every day in the everyday clinical practice. So let's say that this is my disclosures, obviously, about this presentation. And the main thing when we talk about foveal hypoplasia is what we actually talking about. Because we wonder if we are actually talking about a new definite or a specific clinical entity, is one of the wonderings of the present time, or instead we are talking about a clinical sign that helps to guide the diagnosis. No matter what, we need to know how is the clinical significance of these findings. So I'll show you the pathways or the punchline of this webinar that will start with the, I hope not so heavy, theoretical part with what we know today about the foveal development and the physiopathology of foveal hypoplasia. And the second part, I'll give the speech to Dr. Pina Fortunato that will show you the clinical setting, what we do when we encounter a patient with foveal hypoplasia from a clinical point of view. And you'll see the chatting between Dr. Pina and Dr. Sara Bargiacchi from the ophthalmology and the genetic part to see different point of views that allow us to arrive to diagnosis. And in the third part, you'll see the molecular findings about foveal hypoplasia and what we know from the genetic point of view. And so we'll start with part one about the theoretical part on foveal development. Today we know that actually foveal development is a complex molecular process. It starts very early in life. There are studies that find a differentiation of macular structures from the mid-gestation from 14 to 22 weeks. And now we know that the foveal maturity is supposed to be at around 15 months of age. But actually, new papers are deepening inside to this because it is demonstrated that the process of foveal development probably continues and at least until childhood, because it is demonstrated that the outer nuclear layer increases in thickness at least until the 12 years of age. And we know that ONL contains the nucleus of the photoreceptor. And it is interesting that during retinal development, there are two main molecules that guide this process. Actually, namely melanin and dopa. And neuronal cells, because photoreceptors and retina are actually neuronal cells, for the migration, differentiation, and the spatial distribution are actually driven by these two molecules. And for instance, we know that the TIR gene, which is the main gene implicated in ocular albinism, is actually the first actor in increasing the L-DOPA within the RPE cells, and increasing L-DOPA via the OA1G protein coupled receptor increases pigmental epithelium-derived factor that is actually related to the normal retinal development. And together, the L-DOPA is also an essential part of the normal routing of these pathways. And it is not the case that key mutation in TEER gene affects both the normal retinal development and the normal routing of optic pathways. As we say, the foveal development is actually a complex molecular pathways, and we know that there are several genes. I showed you only 4, but there are many others. We know that in different ways, but all genes implicated act on the pillars of foveal development. There are actually 3 to 4. This is the first one is the extrusion of the plexiform layers from the foveal zone, the increasing of the lengthening of the outer segment of the receptor, the widening of the outer nuclear layer, together with the centripetal migration of the photoreceptor. All the respect of those pillars conduct to a normal foveal development. And it is to acknowledge the great work made by many work and co-workers. I show you a very good paper from the group of Leicester, led by Mervyn Thomas and Ivan Gottlob, that actually demonstrated there is a grading of foveal hypoplasia according to those pillars. They took the extrusion plexiform layers, the shallowing of the foveal tip, the outer segment linear, and the outer nuclear layer widening as the main things to classify foveal hypoplasia into 4 degrees. And it's very practical for everyday clinical practice. They found also that there is an atypical form of foveal hypoplasia where this pattern is not respected, for instance, for this gap in the photoreceptor layers that actually is not present in the normal foveal hypoplasia pattern. And thanks to this, we can speak between clinicians on the degree of foveal hypoplasia and to see if there is a relationship between phenotypes. And in our mind, as clinicians, there is that the foveal development, we think this is actually something that is happening only early in life. But actually, the increasing knowledge about this allows us to say that it's a false statement because, actually, as we said before, the foveal development continues at least until childhood, but also until adulthood. And actually, the macular morphology is a real expression of the brain plasticity. There are studies that show that also the amblyopia patients show a morphology differentiation of the macular structures, as the albinism also shows the plasticity in the early childhood. So it is incorrect to say that the foveal development process is something very early and does not change during time. And the definition of foveal hypoplasia today is actually a perturbed foveal development process that results in a structural foveal abnormality. Okay, but from the practical point of view, on what we have to focus when we talk about foveal hypoplasia, we've seen that there are typical and atypical forms. The typical forms are actually more homogeneous forms of foveal hypoplasia instead of atypical ones. Because actually the typical form is characterized by an underdeveloped fovea, but actually intact individual retinal layers. And as we saw, the atypical forms are actually present at the inner retinal layers, but are sometimes abnormal with part of them, of the cases, a disruption of the photoreceptor layer. And also, the other anatomical landmarks, like the outer segment lengthening and the foveal vascular zone development, are something to put the attention on. Because the outer segment lengthening, actually, it is the big difference between the grade 1 and 2 and 3 and 4 grade of foveal hypoplasia. And it is interesting that is also demonstrated a relationship on the phenotypes, because recent papers demonstrated that cases related to FMRD7 mutations are quite often associated to grade 1 and 2, while ocular albinism and Darmansky-Pudlak syndrome are strongly related to grade 3 and 4. For the ocular albinism, actually, we cannot have this such definition, because they can present both from grade 1, 2, 3, or 4. So there is a lot to know yet on this side. And also the foveal development is interesting too, because as we know, with the OCT angiography, we can study the superficial and the deep vascular plexus. And it is interesting to know that the maldevelopment forms such as ocular cutaneous albinism actually do not present or minimally present the foveal avascular zone. Instead, the forms of such a achromatopsia, is namely an inherited retinal dystrophy, do present with the normal or quite normal foveal avascular zone, at least at the beginning, and after that, probably the dysfunction of cones can not, it's sometimes related with the inner retinal layers, but actually do not perturb the displacement of the vessels at the posterior pole. That is demonstrated one of the main pillars to favor the packing of the cone photoreceptors at the foveal area. This is from the anatomic point of view. And from the functional point of view, we can bear in mind that usually typical forms of foveal hypoplasia has usually worse visual acuity than the typical ones. This is not such a big difference to bear in mind, but we can also think about that handled OCTs are helping us in the definition of this connection between anatomy and function. And this is the recent paper led by ERN-EYE that is actually demonstrated this relationship, and it is interesting, for even if it is mainly focused on albinism, infantile nystagmus, and achromatopsia. And we think that new devices and technologies such as, for instance, adaptive optics will help to fill this gap between genetics. Thank you. So at the end of this first part, we can conclude that we have today a lot of knowledge about foveal hypoplasia, but it is still incomplete for a proper genotype-phenotype correlation. And as I say, as we are clinicians, and so we want to know how to translate all these informations into clinical practice. So I think that the best way to do this is the clinical scenarios, and in the second part, you see Dr. Fortunato will show this peculiarities.
As Giacomo said, it is important to evaluate the clinical setting in our clinical practice. And in fact, we know that foveal hypoplasia is a classical albino phenotype. In fact, in typical ocular albinism and oculocutaneous albinism, we have various characteristics such as iris translucency, nystagmus, misrouting of optic pathway, strabismus, reduces stereoscopic vision, fundus hyperpigmentation, and variable skin and hair pigmentation. But now it's good to know, but let's see some challenging concepts and describe, for this reason, various cases. For the first is case 1 and 2. This is a case of brothers, first seen at age 4 and 7 years old, and now the first have 16-year-old and last one 19 years old. They haven't nystagmus and a low visual acuity, is not present the iris translucency, have a height myopia and normal color vision, but have some behavioral problems. We have a great difficulty examining these brothers. Have another characteristics: poor night vision and mild photophobia and unremarkable family history. Now, the case one is a case of one of his brother, and we have at the fundus ophthalmoscopy unremarkable the characteristics and Foveal Hypoplasia, low grade of Foveal Hypoplasia. And we also have another characteristic, important characteristics, because during the OCT examination, we find RNFL thickness very low. The second case is the same. For we have a fundus ophthalmoscopy, myopic fundus ophthalmoscopy, the same low grade of Foveal Hypoplasia, and also in this case at the OCT examination, RNFL thickness very low. We also examined the full field ERG, and its important aspect, we find a negative ERG, full field ERG. In summary, the point of these cases are low visual acuity with eye myopia. The second, low grade of Foveal Hypoplasia. Also, the low values of RNFL, and at the end, a full field ERG negative. What are the differential diagnoses? They have an achromatopsia or isolated syndromic eye myopia phenotype, or a typical form of albinism, con dysfunction syndrome. What else?
Good evening to everyone. So in these two boys, by whole exome sequencing, we found a mutation missense mutation in CACNA1F that was subsequently described by Professor Zeitz in 2019. So as you know, CACNA1F is located on chromosome X and is quite a large gene that encodes a transmembrane protein, a subunit of calcium channel CAP1.4, and is expressed in the outer plexiform layer of the photoreceptors. As you know, this gene can be associated with various phenotypes. The main one surely being congenitally stationary night blindness type 2A, but we can also find mutations of these genes in common neural dystrophies and in island eye disease. That is probably the most fitting diagnosis for these two boys from a clinical point of view, and also in some rare cases of early onset eye myopia. And for this gene, what we need to remember that these patients that most commonly have night blindness and photophobia, they frequently have an electronegative aspect at ERG. And in general, we can also say that from some recent works, CACNA1F mutation can be associated with an involvement of the optic pathways that seems to be mainly subclinical, but stable in time. So now I leave you to the second case.
So we have another case, case 3. We have male, unsteady fixation with nystagmus onset at age 1 month, no iris translucency, mild to severe photophobia, fulfilled ERG flat response or optic unit, and no major extraocular features, mild astigmatism, and family history unremarkable. Now, this is fundus ophthalmoscopy and OCT exam. Also, in this case, we have a low grade of foveal hypoplasia and normal aspect of fundus retinography. And the full field is of described an absence of photopic traces. Summary: congenital nystagmus and photophobia, atypical foveal hypoplasia, normal fundus appearance, a fulfilled ERG with dysfunction in photopia. What's the differential diagnosis? Idiopathic infantile nystagmus syndrome, or atypical former albinism, or cone dysfunction syndrome, isolated foveal hypoplasia, or what else? Explain us, please, Dr. Bargiacchi.
So in this boy, two mutations in CNGA3 were found. These are both reported mutations in literature, one from the mother, one from the father, and this allowed us to confirm the diagnosis of achromatopsia. CNGA3 is a really short gene, and again, it encodes for a cation channel protein that is expressed mainly in the cones. And these patients, as you know, they show mainly photophobia, reduced visual acuity, nystagmus, and inability to discriminate between colors. At the ERG, we can find a major cone impairment, and what we need to remember is that this mutation in this same gene can also cause different phenotypes, like cone dystrophies, in particular for some hotspot mutation. So clinical genotype-phenotype correlation is always important. Now on for case 4.
The last one, case 4. We have a female, a poor fixation with nystagmus onset at age 2 months, no iris translucency, a normal fundus appearance, a mild hyperopia and astigmatism, no major extraocular feature, family history unremarkable, and firstly send to the neurology department for workup. During the sedation for MRI, we also find with the OCT exam foveal hypoplasia, but a normal nerve fiber. Summary: congenital nystagmus, high grade of foveal hypoplasia, normal fundus appearance, no fulfilled ERG data, and in this case, the differential diagnosis is atypical form albinism, isolated foveal hypoplasia, or what else?
In this girl, we found a missense mutation in compound heterozygosity with 2 exon deletions in gene SLC38A8. This is the gene that is encoding a protein that is part of the pathway that is a melanin-independent pathway that is essential for the development of fovea and the optic nerve. And the phenotype that is associated with this gene is summed up by the acronym FONDA, that stands for foveal hypoplasia, optic nerve misrouting, and in more or less 20% of the patients also possible anterior segment dysgenesis in the form of accent field anomaly or endotoxin, without any signs of albinism, because as we said, it is part of the melanin independent pathway. now that we have finished the clinical cases, I think we can move on just for a recap of genetics in foveal hypoplasia from a strictly molecular point of view. For talking about genetics in foveal hypoplasia, surely the most common associated condition is albinism, and that most albino patients show foveal hypoplasia. And this association is very strong also for patients with Bacci mutation and SLC38A8 mutation, whereas foveal hypoplasia is present but less represented in patients with achromatopsia and FRD7 nystagmus. But now if we go on and we so talking about albinism, what we can say, this is, I said, the most common condition in which we can find foveal hypoplasia. It's a group of conditions in which we have reduced or absent melanin production in the ectodermal tissues. And the most common types are oculocutaneous albinism, followed by ocular albinism and the syndromic form of albinism, like Hermansky-Pudlak or Chiadiachi-Gashi. You know, if Chiadiachi-Gashi is quite rare, Hermansky-Pudlak instead probably is more common than what we think, because especially for block 1 and block 2 genes mutations, these occurrences were quite mild phenotypes, so they probably can go underdiagnosed or incorrectly diagnosed as albinism or ocular albinism. And now what we can say is that if we consider, if you consider what often our clinicians encounter, we must also say that one of the most common presentations, not next one, this. So as a common presentation is also isolated foveal hypoplasia. And the first gen we should think in this situation are probably Bacci, where missense variant gene can be associated with foveal hypoplasia with cataract, nystagmus, and invariably anterior segmentus genesis. Then we have Fonda, as we said before, because this phenotype can be characterized by foveal hypoplasia and optic nerve misrouting without any defects of the anterior chamber. And then we have in literature 2 records of the gene AHR and the allelic mutation associated to isolated foveal hypoplasia with nystagmus. So move on, please. Also, we should think about foveal hypoplasia, obviously also in association with other retinal conditions. And as we said before, we can find foveal hypoplasia as a sign in CACNA1F related disease or in achromatopsia, but also in some other more systemic conditions like Stickler syndrome, Fabry disease, or also in West maculopathy. And now, as an example of genetic heterogeneity of foveal hypoplasia, I wanted to present you briefly a short case series of 8 patients from 6 unrelated families. And this patient presented with a subnormal BCVA and a variable degree of foveal hypoplasia at OCT. Also, this patient had quite normal hair skin pigmentation, and that's why we define them as with a diagnosis of isolated foveal hypoplasia. So we studied this patient with ophthalmic technique and also by a molecular point of view using exome sequencing and studying the genes that are mainly related to foveal hypoplasia. Now I'll let Dr. Bacci comment on the clinical part, and then I'll be back for molecular findings.
Yes, as Sara, you can see the quality of the image is not so high, but you can see that there is a mild degree of fundus pigmentation in all patients, and all patients show it up with variable degrees of foveal hypoplasia and the striking appearance of no iris translucency in all patients. And we think about that doing the VTs would be useful to know there is an abnormal crossing of the nerve fiber layers. As we know that in pigmented, it's 45% of uncrossed axons, while in albino patients there are 10 to 20% of uncrossed axons. And we studied them with these VTs that in an albino control, just to have a comparison, as we know that the counterphase waves that demonstrates actually the misrouting of optic pathways. And as you can see, in all patients, a variable degree of misrouting of optic pathways was present. So confirming that adding with the low degrees of foveal hypoplasia, variable degrees of foveal hypoplasia, a good retained visual acuity, no iris translucency, no nystagmus, and slight fundus pigmentation do present with many features of ocular cutaneous albinism. And this is the result of the genetic part. Please, Sara, can you show this?
Yes, so in all of our patients, by molecular analysis, we could demonstrate mutation in tear, and more specifically, 7 out of 8 patients showed a specific allele that has a specific genotype that is already known in literature to be associated with OCA type 1b. And this allele comprises one inactivating variant on one allele. In trans, with two known polymorphisms of tear that taken together in a recent work from American colleagues, they are indicated as the cis-YQ allele. And we know that this genotype has been already associated by a lot of works with a mild albino phenotype. But if you move on, Giacomo, we will show the genotype of all our patients. We find this genotype in 7 out of 8 of these patients, while the last one had to be allelic inactivating mutation. So what we got from these case series, if you could move on, next slide, Giacomo, is that we started with a series of patients that had an extremely mild phenotype of isolated foveal hypoplasia, but we, after this, could relocate them in a mild OCA1b phenotype. This patient had a strong preservation of the CVA, and initially they were considered isolated foveal hypoplasia. But if we think to the deep genotyping and phenotyping of the patients, what we can understand is that probably this permitted to us to give them a measure definition in clinical, and this will probably tell us that tear mutation can have a spectrum of phenotypes ranging from an apparently isolated foveal hypoplasia towards the severe end of the OCA1A phenotype.
So, can you hear me now? Yeah. So, as we saw, the foveal hypoplasia is actually a clinical entity with some peculiarities that are yet to be discovered. And just because if we think that even patients with SPG7 mutations, namely affected by a form of hereditary spastic paraplegia, presents with this kind of features, such as foveal hypoplasia, and also patients in the spectrum of non-ophthalmos, microphthalmos affected by MFRP or PSCRSS56 mutations can present with variable degrees of foveal hypoplasia. And also patients with metabolic disorders related to cobalamin C intake can present not only with maculopathy but also with the degrees of foveal hypoplasia. So this can show that there is a lot that we have to yet to know about the development of the fovea. And to go back to the first question points, we think that it is more likely that the foveal hypoplasia, we can consider it more the clinical sign that helps to guide the diagnosis instead of the really new definite and specific clinical entity. But it is just a thought on what the literature show until today. I'll leave you with some key points. We see that the OCT really changed our clinical practice, and the handheld devices will offer, obviously, an useful tool on an early genetic diagnosis because it is more feasible also in awake children, not only under sedation, and probably it will spare unnecessary MRI sedations. I think we have, as clinicians, pinpoint to the ancillary symptoms. As you see, the presence of a strong photophobia, clinically evident, and the performing of full field ERGs can help us to define the molecular parts to be considered when we have foveal hypoplasia. Possibly during time we can have it would be necessary to have a revision of the classification because new data, new papers, new studies will rise more knowledge about it. But today it is very, very good for, as I saw, for a clinical practical point. And I hope to show you that a multidisciplinary team is actually necessary to make an assessment of foveal hypoplasia, especially in case of syndromic form that are quite not so rare as we tell. And the genetic test alone, as usually it is a very powerful tool, but not enough without the phenotype. At the end, I'd like to thank the whole iGenetics unit. All the work that I showed you would be probably impossible without the help of my co-workers and collaborators. So I think I owe them a word to thank all of them. And thank you again for your attention.
Thank you for all the team from Florence to this presentation. Thank to all attendees also.